All right. Hello, everyone. Welcome to today's conversation. My name is Dr. Stephen Smith. I will be the host for today. We're going to give it we're just starting here, but I want to give at least a little bit of time for folks to chime in, to check in. We're having hopefully some folks from the East Coast, West Coast, all around, and I know it's afternoon over here on the East Coast and morning time over there on the West Coast. So please, as you join, just shout where you're coming from, shout your city, um, even if you want to provide your name or a school that you're representing. We'd love to hear from you guys. So utilize the chat function, please, and we'll just take a few more moments for folks to join before we dive in here. All right, welcome everyone. Welcome. All right. Hello, everyone. Once again, hi, welcome. Welcome to today's conversation. Please join us by sharing your name, where you're coming from, where you're watching this from, school that you want to represent, anything that you'd like to do. Just shout yourself out, please, on the in the comments section. We're gonna get started. We're gonna give it maybe another minute before we dive in here. Give folks an opportunity to come in and get settled. All right. Hi, folks. Once again, just want to just really quickly give you a welcome here. If you are here for the Steve Funds conversation about psychiatry, you're in the right place. Thank you guys for joining. Let's go ahead and get started. I know we have a lot to talk about today, and we are very excited to have our speaker today, which I'll introduce in a moment. Welcome, everyone. My name is Stephen Smith, Dr. Stephen Smith. I'm a clinical psychologist, advisor with the Steve Fund. We are really excited to have you here, really excited to talk with you today about some really interesting topics in psychiatry. Um, so a little quick intro about the Steve Fund. Some of you may be familiar with the Steve Fund, but I want to just give an opportunity to give a little bit of background about the Steve Fund. So the Steve Fund is actually the nation's leading organization, which focuses almost exclusively on the mental health and emotional well-being of students of color. As you'll get to know the Steve Fund, we work with colleges, universities, nonprofits, corporate organizations to really stimulate dialogue and promote effective programs and supports and services to both understand the emotional and mental health needs of young people of color, but to prioritize their mental health, and especially for those transitioning from undergraduate to higher education. So we would love for you to just be on the lookout for our future events here. We're bringing this today's conversation as part of our Medical Students of Color initiative. And essentially, this initiative was started to really, as with the Steve Fund's mission, and not only address the needs of young people of color, but specifically address the needs of young people that are in medical school or those aspiring to go to medical school. As you'll see, this is one of our monthly conversations. We have a host of other events that we hope that you'll take a look at, from workshops to different types of support groups, and we'll definitely get that out for you guys. So please, stay in touch as we unravel this initiative. As you'll see, today's conversation is going to be very conversational. There will be some information that's presented on a slide, but we hope to make this as interactive as possible. So utilize those chat boxes. Please post your questions. We want to make sure that you don't leave here with questions unanswered. So we will be posting some questions to you guys for you guys to answer, but we do hope that you would also ask us some questions. And our presenter today loves to kind of engage the audience, so we're hoping for some really interesting questions here. You'll also notice that we're going to do this conversation, and at the end of the conversation, we're going to save about 10 minutes or so, where you'll see a link, a QR code to our survey. If you can, please complete the survey. We obviously we want to hear from you guys during the conversation, but also after, if you have any feedback that you'd like to share. So you'll see the slide deck that has that QR code. And if you don't, just let us know. We'll make sure that we get that to you. Okay. All right. So as again, welcome, guys. Please shout yourself out where you're from. Are you from the East Coast, West Coast, Midwest? Please, we'd love to just kind of see who's in our audience here. Share your name, share your school, share what level, where you are in your academic journey. All those things are really welcome, and we'd love to hear from you guys. Okay. All right. That being said, so we talked a little bit about the Steve Fund. We talked a little bit about this Medical Students of Color initiative in particular. We are really, really happy to have as our guest speaker this month, Dr. Angela Coombs, who will be talking about a conversation entitled Psychiatry and You. A little bit about Dr. Coombs. She currently serves as the Associate Medical Director at Alameda County Behavioral Health System in North California, excuse me. She also works clinically as a public psychiatrist in East Oakland, California, as well as maintains a small telepsychiatry private practice. Prior to joining Alameda County Behavioral Health in 2021, she was actually based here in New York City, where she served as the medical director and team psychiatrist for an organization called On Track New York, located within Washington Heights / Columbia University. And that was a program dedicated for providing services for young people that were experiencing early psychosis. While at Columbia, during her residency training, she served as chief resident and went on to complete a public psychiatry fellowship there. Her scholarly work has focused on mental health inequities facing Black American populations and other minoritized groups, as well as partnering with non-medical institutions such as churches to promote healing and recovery for underserved communities. So we are excited to have Dr. Coombs here. I'm excited as I actually know Dr. Coombs. I've worked with her, and she's just the epitome of Black excellence. And really happy to have you here for this conversation.
I'm so happy to be here.
All right, great. Again, guys, you'll obviously hear from Dr. Coombs in a minute, but please shout out where you're from. Shout out, kind of, who's in the audience here. We'd love to hear from you guys. Okay.
Oh, Dr. Brim.
Dr. Prim. Hi, Dr. Prim. Really nice to see you. And Dr. Prim actually gave was awesome in our first learning community mentoring conversation. So hopefully you have a chance to check out that as well.
That's beautiful. You guys kicked it off with the goat. Like,
Yes, yes,
better than that. Hi,
yes,
Dr. Brim.
yes. All right, awesome. Okay, so let's kind of get in here. The conversation today is entitled Psychiatry and You, and you're going to be hearing a lot about the perspectives of Dr. Coombs and her journey. But first, we want to just maybe open it up to you guys and get some ideas of what comes to mind when thinking about psychiatry. And I'm gonna turn it over to Dr. Coombs here. I know that there's a scenario that you want to just kind of explore.
Yeah, I think starting off by inviting everyone to sort of engage with our own underlying assumptions about who and what a psychiatrist is. I know I have my own notions about what a psychiatrist does, what a psychiatrist looks like, what maybe their orientation to thinking about people might be. And it's important for us to sort of examine some of those notions, because I think that we can end up carrying those underlying assumptions and it show up in ways, maybe in ambivalences towards pursuing a career in psychiatry. So I just wanted to start with like a little scenario. So if you picture maybe a father who's 65, he has a couple of kids, um, and he has had experiences with recurrent episodes of depression, maybe a few times over the course of his life, but he's had the benefit of working with somebody who really he has a strong relationship with, a psychiatrist that he has a strong relationship with. And even though it had been a few years since the last time he had a depressive episode, he is now experiencing another one and is really scared about what that might mean for going to work. It's been challenging to go to work. It's been challenging to sort of show up and be present in the lives of his children the ways that he wants to. So he comes to the office and sits across from this psychiatrist that he's had this long-standing relationship with, whom he truly trusts. So as I describe that scenario and you look at the psychiatrist that he's talking to, who's coming to mind? First of all, there might be an image you have of even the patient that I described. But who's coming to mind when you think of that psychiatrist? And you can feel free, even in the comments, like, shoot out different words that come to mind. Um, is this individual of a certain gender, a certain age? Do they have a certain hairstyle, a certain complexion? Are they speaking a certain language? Is it automatically coming to mind if they're talking? Is their assumption that they're speaking English in that interaction? And I just want us to sort of welcome and sit with that. And maybe I'll give you another quick scenario. There's a young woman who comes to the emergency room, and she actually had been found down on the street and was sort of revived. It was concerned of her having overdosed from something. And in the emergency room doctor wants a psychiatrist to come speak with this young woman. And maybe there are a lot of questions about, was there an intentional overdose? Was this a suicide attempt, perhaps? But nevertheless, the emergency room doc wants a psychiatrist on board to engage with this young person. So in walks a psychiatrist to the medical ER, the section that they might have, roped off or sectioned off for patients and that might also be waiting to be seen by psychiatry. And that psychiatrist introduced themselves. Who are you picturing in that scenario? Is this person look the same as a psychiatrist in that office? Is the gender the same? Are they using an assist device? Are they able-bodied? And so just like thinking about some of what comes to mind when you think of a psychiatrist, I'm hoping that in this conversation that we have today, that we start to ask ourselves explicitly questions about who has felt welcome and included in this profession, why that might be. And, if you found yourself, even in these scenarios I brought up, different examples, if you found yourself imagining a psychiatrist that looked like you, then like you're ahead of the game. That's a beautiful thing. Because oftentimes people feel like it's hard to sometimes see themselves in that role. And so I kind of want to walk us a little bit through that. And hopefully by the end of this, you can see why we absolutely need you in the field, and why it's absolutely of urgency that you feel like you can be a psychiatrist, and challenge some of the underlying assumptions about if you felt like before that you might not be able to, or at least felt like maybe this doesn't gel as much for you as for somebody else. So I'll just briefly share a little bit about my journey before getting into some of the presentation piece. And I also see someone shouting out that they're from East Connecticut in the building. Okay. Yes, please keep on putting in where you're from. And I'm on the West Coast. We got any West Coasters over here? I'm not from the West Coast, but I'm in the West Coast. But yeah, let us know where you're coming from. We really want to be able to engage you all. And let us know also where you are in your journey, if you're in med school, if you're undergrad, high school. Yeah, so I'll share a little bit about my journey. So I certainly did not set out early on thinking about psychiatry. But even before thinking about starting with, and that is true. The West Coast might still be asleep. It's a little bit earlier on our end. So when I was thinking about pursuing medicine, I think one thing I want to say for any of you, if there just happen to be anybody in the audience who is not a med student right now, but is on that journey or wants to pursue medical school, that it obviously is not without its own challenges. There's a reason why so many of us are underrepresented within the field. So if I can give just one pearl of advice, because it made such an immense difference in my life, is that, you know, it's very easy, I think, to be discouraged along the way at times if without adequate supports. So finding living, breathing examples of people who traversed obstacles or who can tell you about different insights about the journey is key. Don't be afraid to cold call LinkedIn, whatever it may be, physicians or people along in their training to ask, could you give me some advice or words of encouragement? For me, when I was in college, I started off in actually a pre-med program that was specifically for folks coming from underrepresented groups, racial and ethnic backgrounds. But there was a cohort of us that were interested potentially in pursuing medicine. I was also thinking about maybe social work. I really also was caring a lot about social justice and sort of the intersection of medicine and social justice. But what was really sort of discouraging is as we all went along college, the numbers of people, my Black and brown sort of cohort, started decreasing. And by the time that I ended up applying for med school, I was the only one in that cycle actually applying, compared to the whole group that we had started off with actually, a few weeks before freshman year. And so I know for a fact that along the way there are so many implicit messages that get told, and I don't even know if institutions mean for it to be this way, right? But intentionality is actually not relevant here. Regardless, there are some implicit messages that, maybe this is not right for you, or not the right path for you, or maybe you're not a stellar student enough, or your sciences are, it's like this, or maybe it's going to be too difficult to afford. And so slowly but surely, those messages start to really creep in, and people can find themselves as sort of an attrition. And for me, what was transformative was I had a living, breathing example of someone who did it. So I had the privilege, and really is a privilege, of my own mother who was a physician, and she was one of the fiercest advocates I knew for social justice and medicine growing up. And so when I didn't get the grade that I wanted, or when I felt like, oh, I don't know if I'm really enough, I don't know if I'm enough to pursue this, she could tell me in so many words, it's absolutely not true. But I know that a lot of other folks didn't necessarily have that. So it doesn't have to be obviously someone in your family. That's a privilege, right? To be able to have someone in your own family who's been able to navigate some of the obstacles. But reaching out to people outside of that, I think, is so key. So let me just fast forward into talking about why psychiatry. So when I started med school, I really did enjoy the beginning of it. You do a lot of classroom work, but I found a lot of it still very fascinating and very interesting. But I also found that it was really hard to do anything else outside of med school. And before that point, I was kind of always dabbling in different things and different interests. Because even college and high school, there was still some room to pursue other types of things. But med school was so demanding. And I found that before I knew it, I was almost about to be done with my preclinical years, and expected maybe within a half of a year into my clinical years to sort of know what I wanted to pursue. And it just felt so unrealistic, because while I was learning a lot about the sort of science and medicine, I wasn't really learning as much around, what's happening around real life social determinants that come to shape health outcomes, or the ways in which I want to kind of show up in the world as a physician. So I pursued a research gap year, which I knew would allow me room to not just do research, but pursue other things too. And actually was in the Bay Area at the San Francisco Department of Public Health. I mentioned that year only because it was so transformative for me, because I got to do a whole lot of living. And even though I was funded to do, at the time the research was around, there was an HIV vaccine study going on that had really low representation of Black, gender, and sexual minorities. So I was looking at an intervention to help improve some of that. what ended up happening is all these Black HIV advocates who have been doing work for so long, sort of even outside of academia, like in the community here in Oakland and in San Francisco, sort of took me under their wing as this student that was sort of eager to understand and sort of meet the community where the community was. And they really poured into my life, and they really empowered me around, like, this is take this back to you when you finish med school. Like, we need docs that look at our communities this way and connect in this way and bridge the gaps. And it allowed me to come back to med school so revived. I wasn't just sort of in the classroom, but I felt like I had room to think about other interests and how they might work in the future with what I pursue. Still wasn't thinking about psychiatry though. And part of the reason why I wasn't thinking about psychiatry is my own internalized stigma. So I grew up having my own sort of conceptualization of what mental health or mental illness was about. And part of this was even sort of intergenerational. So um, I grew up with, very close to my father, and I grew up hearing these beautiful stories of his relationship with his mother, all the time that they spent together, how much he loved her, but also of her sort of tragic and premature death. My paternal grandmother had been diagnosed with schizophrenia and been involuntarily hospitalized on multiple occasions. And I always felt sort of horrified by this idea that could have her engagement with the medical establishment and psychiatry have led somehow to her like demise, like had led for her premature death. And I knew how traumatizing her death had been for my father. Um, so I kind of stepped into med school already with all kinds of notions that are sort of out there in general, stigma related to mental health and psychiatry, but also my own narrative, the experiences within my own lineage that made me really intimidated by it. But when I started my psychiatry clerkship and I was assigned to work with a woman, an African American woman who had arranged with her psychiatrist to be admitted in advance to do ECT, electroconvulsive therapy, as a treatment that is pretty effective for depression. And she had worked well for her in the past, and she had arranged to come in again for it. I was really struck. First, it was amazing that this woman, despite sort of on the hierarchy of your medical team, I was the medical student, so I was sort of the lowest on the totem pole, but she chose to allow me to really be sort of spend time with her and to tell me her story. And when she had first came to the unit, she didn't really share much. She was so depressed that it was really hard, I think, for the rest of the team to, and myself included, to sort of engage her around some of the different pieces of her life. But I watched as she received treatment that she started to share more, and she started to tell me so much about her journey, about her hopes and dreams and nightmares and the frustrations. And I had never seen something like that. I said, this is like a really powerful kind of healing and recovery. Coming off of other rotations where you saw really sophisticated treatments. At the time, there was the TAVRs, the aortic valve replacements that they do through a catheter, were like new, and they were very expensive. And I remember watching somebody come to afterwards, but then in talking with that patient on that other service, they didn't really feel like their life was that meaningful. They didn't feel like they were connected to their family in the way they wanted to be. So it felt like, wow, there's so many of these sophisticated biological interventions in medicine, but what about how somebody feels in their life? Um, so it really was transformative for me to be able to sort of journey along with that woman while she was hospitalized at that time. And yeah, I told the clerkship director that I thought it was fascinating and powerful. And he's like, oh, those are dangerous words. He's like, you might become a psychiatrist. And I was like, oh my God, really? And that was the start of the journey. And really what the journey has been like since that point is a series of learning so much about the different modalities of treatment, but also unlearning, also questioning the ways in which some of those modalities serve some people, but not others. And why is that? Or the ways in which there are so many resources, but then, how do we miss the mark? Or how does the traditional way in which systems have been structured miss the mark for different people? So, that's sort of the way I hold psychiatry now, is that there's so much potential, and I've been able to bear witness to and partner along with all, many different clients and patients and seen their recovery firsthand. But I've also seen many different harms and people experience traumatization from the system. And so we need to both imagine a better future and enact a better future. And I really believe that bringing more people in with different lived experiences is actually a part of that, and why today's event is so important.
Wow, thank you, thank you. I mean, you so many jewels that you dropped there, and just to kind of think about what you said, right? Like your journey really highlights what we hear from a lot of people. Um, these impediments that happen along the way. You mentioned that from school, these subtle messages that can deter people or tell people maybe this is not the profession for you. Maybe med school isn't for you, right? Subtle ways of saying that, try something else. And you also talked about factors related to stigma and kind of the history of mental health, particularly with Black and Brown communities, and how that ingrains a perspective about the mental health field that likely keeps us away from engaging it, let alone trying to become a part of it, right?
Mm,
And so I just, it just really highlights a lot of the ways that these both seen and unseen forces can either push you into the field or actually keep you away from the field. And so
right.
um, that's really awesome. And just again, a lot of what you talked about too was this idea of being an only person in the space
Mm,
that looks like you. Um, and a comment made about how powerful that is to have a professional look like you as a client, or even vice versa. So
mm,
you really want to highlight that. Thank you. Um, Folks, just want a quick plug to please continue to use the chat room. We're having a conversation here, and I don't want it just to be a conversation between me and Dr. Coombs. We'd love to hear from you guys.
yes.
Um, we're going to be here for a little while here. All right. So you spoke about kind of your journey, and I know that a part of the journey, a big factor for you was this idea of like needing to uh, take up space and needing more people that look like you in
Mm.
such an important field. I wonder if you could just maybe speak a little bit more to that type of need of seeing more Black and brown people in our workforce, and why there isn't as many of us in there.
Yes, yes. So you know what? Let me share these slides, and I'm gonna because I think it's helpful sometimes to have visuals to look at, why the disparities are what they are, or at least some aspect of them, but then also why this intervention really matters. So, just to start off, part of the challenge of when we talk about, being a minority is it can sometimes have that, little connotation as if we're somehow small, but that's not what that means. And I highlight also that, to using term minoritized in this context, because part of that is important to conjure up the reality that our groups have the numbers they have for certain reasons. It's not just happenstance that there might be a certain percentage of some groups versus others, right? There are sort of social forces at work. um, but when we look, these are just some examples real quick that I just would give. The first map you see here looks at Black or African American population in the United States being around 13.2%. And this data that these little infographics are from are using data from the US Census, as well as SAMHSA, which stands for Substance Abuse and Mental Health Service Administration. But if you looked at just Black Americans alone and the percentage that have a diagnosable mental health condition in the past year, that would literally be the population of Chicago, Houston, and Philadelphia combined. Similarly, if you look at our U.S. population of folks who are Latino or Latinx, and the amount of people that have a diagnosable condition, it would be more than the number of people in New York City. You go to the Asian American populations, again, more than the number of dentists, post-secondary teachers, and lawyers in the US. So this is millions and millions of people with a diagnosable mental health condition, let alone things that maybe might not meet the threshold, but might be more like psychological distress or different kinds of experiences. So at the end of the day, we're not talking about a small number of people. So I think it's important to have that context when looking at disparities, that when we're looking at things not meeting the mark for different populations of folks, we're talking about this impacting a lot of human beings. So the workforce does not reflect our diversity. And I don't know if you guys can see on the screen with the welcome sign underneath, but in case you're interested in looking, especially for the medical students in the room, for those of you interested in looking at some of the sources, maybe the slides will be available later on. Oh, okay, you can see them too. So just to make sure that you have some of these names in case you want to look into some of this. But we know that the workforce doesn't reflect the population. So the first bar you see at the very top that shows, based off the US Census data, the percentage of different groups, you can see here the bars representing these different underrepresented minority groups. And as you go along on the continuum of training to the point of applicants, so that being medical students, to psychiatry, and sometimes not just medical students, but also maybe people who have done, they might not be actively medical students, but maybe they had a gap year or some other kind of pathway. But then to psychiatry residents, so when you do your residency after medical school, to fellows, for people who choose to do fellowship, you can see these numbers really, these numbers can very much so shift. What takeaway one is that they're not reflecting the population. So the numbers aren't a reflection, but that there's actually greater diversity in our trainees now than there are in our faculty. So, to the person who's commented about, having people that look like you in mentorship, and what I was sharing about mentorship and encouragement, if you're thinking about faculty in your academic program, they're not reflecting the diversity of our general population. So this is a call for pipeline, for why it matters, making sure that we have folks coming from training, but also going to be then the persons who are doing the training down the line and are able to, help mentor folks who are in these training programs. I just want to take a second to unpack this slide. So this is looking at mental health service use in the past year among adults with any diagnosed mental illness or mental health condition. And it's broken down by race and ethnicity. So I just want to highlight a few takeaways from this. So one of the first takeaways is when you look at the numbers for people of all racial backgrounds, they're actually pretty low. So this is not talking about just people in general. This is for people who have a diagnosed condition. So even when you look at white folks who have the largest numbers out of any of these groups, even for them, less than half of folks with a diagnosed condition are actually receiving any kind of service, any kind of mental health service. So I think of it as being like, if you look at an example of somebody going to the doctor and getting diagnosed with diabetes, it's one thing not to know you have diabetes and not to be engaged in health care or not be connected or not have access, but to have access and get a diagnosis, but then less than half not to be in treatment for diabetes is like, that'd be huge, right? But that's what we're looking at when we're looking at the service world right now, is that really less than half. And the other thing I want to highlight is that, is the disparities between these other groups as we see it. So we look at Black and African American, we look at Asian Americans, we look at Hispanic Americans, and we see that it's even worse. I also want to highlight one other point. So these different services, this includes inpatient. So when we think about at the hospital, so inpatient services, it's important to know in the mental health world, for those who are, learning more about psychiatry, is that we think about inpatient hospitals as sort of like the intensive care units of the mental health world. It's a finite resources. There aren't many inpatient units compared to how it was historically. And a lot of times it's the most restrictive environment. A lot of inpatient units are locked. A lot of inpatient units aren't necessarily the most pleasant experience for folks. And there are plenty of people that are going to inpatient units on an involuntary basis, not necessarily like the patient I described when I was a medical student who had made the arrangement to come into the hospital. Many people are involuntarily hospitalized and come into the hospital under those conditions. So when we see the fact that, just let's take a comparison between Black and white individuals in the US, when you see that Blacks are less than 30% of Black folks with a mental health condition actually having any mental health service use, yet they're having a higher number of inpatient services, you have to think, what is going on there? So this is to highlight that the unfortunate reality that, in some cases, people are experiencing our most restrictive, and in some environments, we have to speak this out, some of our most carceral environments. When I say carceral, I mean that for a lot of people, they experience it very traumatizing to be involuntarily hospitalized and sort of surveilled, or to have, forced medication, or all kinds of things that can come with that reality. And I say that as a psychiatrist who knows that at times there have been, things that have happened at inpatient units that allow people to experience the first steps of recovery, or to get well, or to get better. But the reality is there are a lot of harms that have happened to people and continue to happen to people, who experience particularly involuntary hospitalization. So let's look at the fact that we're actually overrepresented as Black Americans, overrepresented when it comes to those numbers compared to our white colleagues or other colleagues, or white peers. So, this is an important takeaway. We're looking at some of the differences, but it's really not the whole story. So when you look at overrepresentation or underrepresentation in service use, it doesn't really tell us what people are actually experiencing while they're in care or while they're in treatment. So I just want to take a quick little case study as an example, because there are so many examples. And, we could look at this in many different dimensions, but let's just take a case with thinking about depression care for Black Americans. So we know that even for people who are in treatment, in care, or have some engagement with the healthcare system, that depression is actually less likely to be detected. And that's even when people are sort of showing up and having access. And if they're in primary care services, they're less likely to receive effective care. So that might mean referral for psychotherapy and psychotherapy sessions, or if they're prescribed a medication to actually be in a dose range that's deemed sort of appropriate for treatment for depression. And I'm just going to give an example here of, when you look at just medications, the odds ratio of initiation of antidepressants amongst depressed adults across this country. So you see here that the odds of being initiated are much lower for Latinx and African American communities and other race and ethnicities. And preference does not necessarily explain this exact disparity. Of course, people's conceptions of medications, how they feel about taking medications, their attitudes towards medications absolutely matter. But it doesn't explain the entire disparity that we see within medication initiation. So there are many drivers of disparities. But part of this sort of our focus today is thinking about why it's so important that you be in the field and why we need to really recruit a diverse workforce. We're going to focus a little bit on the interpersonal for a moment, the interpersonal level, that what happens between a patient and a provider. But you have to really think about the greater context, because even if all our providers are exactly matched to the populations that be, there are still structures that actually are, so the upstream impact of other structures that would still impact some of the disparities that we see. So I just want to make sure that we always have that context in mind. Like, as an example, if there's a public policy that doesn't make sure that every single insurance plan allows for people to access adequate mental health services across the different plans, so whether it be a public plan like Medicaid or Medicare, or a private plan, you'll always end up with differences, because there's not a policy that makes sure that people have that parity or that equity across the basis, right? Independent of whatever doctor you would ideally want to see. But let's zoom in on the interpersonal, on the things that we can change right here and now in our thinking around, why it's so important, who patients get to see. So just a few examples of interpersonal provider level drivers of disparities at times. So ineffective communication can happen. And there are obviously cultural things that can come up that impact how people communicate with each other. Language, as you can imagine, if somebody's not expressing themselves in their language of preference and they have to use an interpreter or a translator, that's a different experience, right, than actually being able to speak in the ways that you want to speak. But one study showed that with African American patients, physicians were actually more verbally dominant and engaged in less patient-centered communication. So this study is really interesting in how they coded for this, looking for when a patient says something about their experience, how that is reflected back, or how much time is spent between the physician talking and the patient explaining their experiences, right? And sharing about what they're going through with the follow-up questions, being able to share more and more. Another study showed that African American patients were more likely to rate their visits with white physicians as less participatory, so less engaging. Now, this is not about shaming and blaming, right? Because there are plenty of docs out there who are trying to meet a variety of diverse patient populations where they're at. But the truth of the matter is that we have a need for people to be able to work with physicians that have lived experiences that might be familiar from them, from backgrounds familiar to them, and be able to have sort of less of these cultural mishaps and moments that can lead for can actually end up impacting some of the outcome of those sessions or treatment longitudinally. And then also the reality that we all have different kinds of biases, but there are explicit and implicit biases that show up in clinical encounters that really can shape outcomes. Another example I'll just mention on that is that we do know, it's been studies have shown time and time again, and for those of you who are already sort of well within their path towards psychiatry, know that there are clear data that shows overdiagnosis of things like primary psychotic disorders in Black Americans, for example, and less likely, again, to that sort of detecting about mood symptoms like depressive symptoms, people then being less likely to be diagnosed with something like depression or bipolar disorder. Which, for the medical students, people can experience psychotic features with those conditions. So the long story short is we need you. Like, we need you, like, I don't know, like it's nobody's business, okay? And the path has its different steps that are sort of required in order to become a psychiatrist. But that doesn't mean it always has to be, super direct. I just want to take a moment, maybe because I know I've been, I just want to make sure to check to see if there's any questions or comments so far before I go into what the roadmap looks like.
Yeah, there's some comments. Great discussion so far, Dr. Coombs. Comments about kind of the idea of
Mhm.
seeing Black and Brown people differently as patients, and the impact that Black and Brown people feel across the board. I think one of the comments of I've heard people say that when it makes a difference when you're around people that look like you. Absolutely, thank you for posting that, and the need to be seen by someone that resembles you and understand what you're going through, and the discordance what that happens when there's a cross-racial dyad in the room.
Mm.
The one comment that I just want to highlight that I think a lot of us have heard, is that when America has a cold, Black people get the flu, right? So this idea
Mm.
that we're experiencing these huge stressors differently, and for a lot of our Black and Brown communities, the added stressor is kind of when the system doesn't acknowledge the pain that they're seeing or sees their pain through different lenses. And I know you've spoken about the overdiagnosis, for instance, the lack of attention in evaluations. All of those things have a huge impact on the emotional and mental health well-being and the type of care that people receive. I want to also just make sure we have some more time. Please keep commenting. Please, we love to hear from you guys.
Yes.
Yeah.
Great. So then I can, walk us a little bit through what this roadmap is. And, particularly for those of you who are on the earlier end of this journey, maybe high school, maybe college, you know, I actually even just, I think maybe 2 weeks ago, got a LinkedIn message from a high school student and, asking what can I do to prepare for this journey into psychiatry. And it's beautiful to know early on that you're interested in pursuing working, in mental health. And I think it's really important, even in high school, to still explore your varied interests. One of the things I think can set people up really well for college is also preparing for those college level science pre-required courses. So there's, with applying to medical school, there are required courses that you have to take. But it can help sometimes to prepare for college by There are sometimes things, the courses that are available online. Sometimes you can audit courses, community college courses. All of these can be good resources for starting to prepare for that, organic chemistry and the college level physics and the different things that will be required of you to take in order to be ultimately eligible to go to medical school. And then in college, you could take those pre-med courses. But I will also say that sometimes, for some folks, it's a heavy load to try to take a lot of pre-med courses all at the same time. And you don't actually have to. There are plenty of people who will finish their requirements and by spreading them out and maybe taking other pre-med requisites in the summertime, not try to having a heavy load, allowing themselves in college to first start off with one or two classes and then building up. Or if they just feel more comfortable, spreading that out so that they can focus on the things that they need to focus on while still trying to excel and give themselves as much time and resources for the particular science class they're taking, you can stretch it out. I'll also say that not everything necessarily has to be done in college. Some people do pursue things like post-bac if you have, varied interest. When you start talking about post-bac, you have to start thinking also about the financial aspect, because those programs, have costs associated with them. So, if you want to think about the different kinds of resources available at your college to be able to stretch things out, perhaps even like I mentioned with summertime, all of that can be helpful because your journey doesn't have to look exactly the same. It doesn't have to be a cookie cutter 4-year college schedule. You can make things, try to make things work for you. And also, don't feel like you have to invest every single waking moment to this journey of medicine. I see, even when I was in medical school, I had the opportunity in my last year of med school to sit on the admissions process. And it's so amazing when you see people do the things that they really love to do that might not be directly related to healthcare and medicine, but totally contributes to how they see themselves as far as being a future physician. So I would encourage you to pursue the things that really are passions of yours that ultimately will make you a better physician because we need physicians with different kinds of lived experiences, right? And different kinds of passions. So med school, it's your 4 years. If you do like a research concentration program or one of these other types of specialty programs, and sometimes it can be 5 years. But really what you're going to be doing in med school and after your preclinical years is trying to explore psychiatry in some of your electives. And I think that the more exposure you get, the more inspired you may be. And also the more you might know about what you're kind of looking for and not looking for in residency potentially. But this is really a good time to find mentorship. And again, don't be afraid to reach out to somebody that you don't really have a connection to or LinkedIn somebody that you never met before and say, hey, like I'm at this school. I don't really have a mentor or, I don't really know any psychiatrists that sort of have a similar background for me or are interested in the kinds of things that I'm interested in. Would you mind just, connecting with me? I can't even tell you how amazing it's been over the course of this journey for myself to connect with med students from all over the country. I truly love it. And I know there are a lot of people like me who really love it. So don't be afraid to reach out to mentors, even outside of your institution. Also looking for interested peers. You don't go it alone. Talk to other people who are interested in psychiatry. So in medical school, there's a program called PsychSign. Now come to think of it, I should have written this probably on the slide. But I believe it's spelled PSYCHSIN, PsychSign. And that's a program that's national that have different chapters at different med schools for medical students interested in psychiatry. Not every med school, I don't think, has a chapter, but if there's a med school in your city or state that has one, you can connect with them. PsychSign is wonderful because you'll get to talk to other folks who are experiencing things on their rotations. They're seeing things. They're wondering about how they can get different kinds of exposure to aspects of the field. So leaning into peers is also really helpful. I'll also mention that the American Psychiatric Association has these different travel awards and conferences that are available for medical students. Get you one of those. It was really wonderful for me when I was fourth year. I got to do an elective for the American Psychiatric Association. And it was incredible. I met colleagues of mine. I met people who I literally to this day know now who are psychiatrists, and it was beautiful. And it's a way to also not have to worry about the financial sort of financial burden of trying to go into a conference and meeting mentors there. You actually can get that paid for. So please check out American Psychiatric Association's travel awards for medical students. So going forward to residency, for psychiatry, our residencies are for the most part 4 years. So that first year is an internal medicine year. The bulk of it's internal medicine, where you're doing some of those requirements, but then you're also getting exposed a lot of times to neurology, and then some psychiatry. And most programs in this country, sort of the 3 years forward is when you're focusing and zeroing on in like sort of exclusively in psychiatry, with exposure to like inpatient services, outpatient, um, different kinds of clinical experiences like consult liaison, which I'll mention in a second, because all the programs in this country that are approved of by the ACGME, that stands for that's our accreditation body, require that you have certain kinds of experiences in residency. I put here 4+ years because there are actually some residency programs that combine both training for adult psychiatry and child psychiatry and allow you to sort of do that all together in a shorter amount of time than would be if you just did a 4-year adult program and then a 2-year child program. You can actually end up doing all of it in 5 years. And then last but not least is fellowship. So, with fellowship, you don't have to do fellowship. But if you're interested in subspecializing, there are so many different programs that can offer rich experiences and that allow you to become board certified in that particular specialty. For example, child and adolescence. So thinking about how do you work with somebody from across the lifespan. Um, Forensics. So that's thinking about for people who are in the criminal legal system, how do we actually address people's needs in that system? Um, Geriatrics, so that's for our older adults. Addiction, that's for thinking about substance use and the interface of substance use and mental health. And it's a long history about why those systems were initially pretty fractured, but it's so important to have people who can work with individuals and be able to really support their ongoing substance recovery and mental health recovery in unison. Consult liaison psychiatry, or psychosomatic is the other name for it, is really around how do you consult with medical teams who are addressing psychiatric symptoms or experiences that are happening on medical units or in medical context. So that might include things like an inpatient cardiology service. If somebody is experiencing acute delirium and is experiencing psychotic symptoms related to that, how can you support them in helping alleviate that person's suffering? Or if you're on a liver transplant team, doing evaluations to see how is somebody's mental health, how are they doing, how are they going to fare when it comes to actually receiving that transplant, are they a good candidate for that transplant, and things like that. So really working together with medical teams to support the whole health of an individual. I put on here one of my favorites, public and community psychiatry. So I did a public and community psychiatry fellowship, and that's really about the systems and understanding how systems are structured to either serve certain individuals and not others, or how are the fiscal components impacting care, all these different public structures and community structures. So I really, for those of you who are really passionate about social justice and thinking about systems, looking into public and community psychiatry, I think, would be a great option. And the last one I mentioned here is reproductive psychiatry. So there are unique needs for folks when they're, throughout their reproductive cycle, whether somebody's becoming pregnant and on medication, how do they navigate treatment for their mood disorder or psychosis in the midst of being pregnant, and how can you make sure that somebody's having the best outcome? People experience things like postpartum anxiety, postpartum depression, postpartum psychosis. How can you address the unique needs of folks in those experiences? So these are just some examples, but the reality is that the journey can look, very different, right? So there's that linear, like, okay, I go to high school, I go to college, I go to med school, I go to psychiatry residency, I get the job. But the reality is that our journeys can be complicated. They can have different routes to them. So I write here to bring your full self to this work and embrace your own journey. And what you see here is a picture of Carnival. So like, I know that me as Angela Coombs, I am my best self at Carnival. Like, that's my happy place. Chipping down the road, okay? Listening to soca music, feathers, all of it. That's the best version of me. Um, and here's just a picture of the roadmap. It's just an example for like one of the bands, and this is from a Kingston Carnival that I went to, and you can see it's not a direct line, right? But how boring would that be, right? Just to go a straight path. No, we chipping down the road, okay? And we're enjoying ourselves. And I don't want to. I'm not meaning to, sort of glorify the process of like, if you're a process that ends up a little bit more expensive, or you know loans. We can have a whole different discussion about loans. I took out a lot of loans for medical school. I still have a small loan from college, so I know, that there is a real financial investment. um, but the reality is that people have different parts of their journey that they hold as feeling like that means that they can't do this work. And I'm here to tell you that it's actually because of your journey, your specific journey, that we need you all the more. We need you in your full, complete self to do this work, um, now more than ever. So I'll stop there.
Dr. Coombs, I mean, such a great message at the end, right? And we think it's timely because it really ties in well to the purpose of our conversation in this initiative. You spoke about the racial disparities. You spoke about the disparities in mental health, but also disparities in the workforce. And it's really imperative that we fill that gap in terms of the workforce, because who else is going to address those disparities?
Mm,
And I really love what you said at the end about like you get to show up and be you, right?
mm,
This is a time when there's finally some recognition that mental health is a social justice issue. And for a lot of our folks, a lot of our attendees, they're very interested in social justice, but seeing themselves in these systems that are often the perpetrators of injustice is hard. It's hard. It's a deterring. So as you laid out, you are actually not just you're allowed to show up as yourself, but we need you, right? The field
yes.
needs you, your ideas. It's clear that these disparities won't go away on their own. So it's really imperative to have as many faces, black and brown faces, at the table, and particularly in the field of psychiatry as we can. It's just such refreshing to hear and see your journey, and I hope others can take the gems and be as inspired as I feel right now. Uh,
Mm,
to really come into this field and may have a strong impact, and there's just so many opportunities once you get in there. um, Guys, listen, I know we are right at the edge. I want to make sure that you have enough time to complete the survey. If we could just bring that back up on and maybe hit that there we go. Awesome. There's the link to the survey, guys. We would love to hear your feedback. Thank you to folks that came and attended. Thank you, most important, to Dr. Coombs for the conversation, for sharing your wisdom, but also sharing your story. We really hope that folks can come check out all of our events here as we really try to support the professional development needs and the mental health and emotional needs of medical students of color. And hopefully, we could get some folks that we can convert and have interest in joining this profession. And anyone else that is maybe on the peripheral that's looking in, very curious, we're here to support you as well. Thank you, guys. Thank you, Steve Fun, for hosting this. And yeah, there's the survey. Please take a quick picture of it and provide some feedback, guys. All right, awesome. Thank you so much, Dr. Coombs.
thank you. It was great to join you today.
All right, take care, guys.